Hello, everyone. Our topic today is about dexmedetomidine, or as they call it uh, on the market, Presidex. I do believe dexmedetomidine will have a huge space in palliative care in the future. It's still underutilized. These are the objectives of our presentation today. We'll talk about the mechanism of action, indications, and side effects of dexmedetomidine. So, the history of dexmedetomidine started at Orion Pharma, which played a major role in uh, developing this drug. Orion Pharma is a Finnish pharmaceutical company. Um, the drug was later on licensed by Abbott, which played a key role in its clinical adoption and global distribution. Orion in Finland and Abbott. Dexmedetomidine is an enantiomer of medetomidine, approved by FDA in 1999. Dexmedetomidine is an alpha 2 adrenergic receptor agonist. FDA approved for use in ICU for less than 24 hours, especially for those patients who are receiving mechanical ventilation with endotracheal intubation. More recently, dexmedetomidine received FDA approval for sedation in the operating room setting or monitored anesthesia care in adults. Reported uses has included also intraoperative administration to supplement general anesthesia, prevention of emergence delirium following general anesthesia, sedation during mechanical ventilation, and for procedural sedation in the non-intubated pediatric ICU patients. Dexmedetomidine comes in different forms, but this is the commonest one, the vial 200 mics per 2 cc. And if you're planning to do any infusion, you want to keep the concentration at 4 mic per ml. Dexmedetomidine is an imidazoline derivative acting on central alpha 2 catechol receptor agonist. Dexmedetomidine is a potent adrenergic alpha 2 receptor agonist. It's 8 times more specific than clonidine, binds to pre and postsynaptic neurons in the CNS. Being a sedative medication, it's not associated with respiratory depression and holding analgesic properties, fosters the interest for this drug in the palliative setting. Again, Presidex, the trade name, or dexmedetomidine. So, as we mentioned, it works on alpha 2 receptors, but actually we found that this alpha 2 has different variants. The most important is alpha A, B, and C. Alpha A is the most important, which is responsible for the analgesia, anesthesia, sympatholysis, sedation, anxiolysis, and hypnosis, and increased cognition. While alpha 2B is responsible for, hypertension, which can happen when you start the infusion. Alpha 2C is responsible for the drug withdrawal and anxiolysis. Dexmedetomidine offers several additional benefits, including effects on only a single neurotransmitter via the alpha 2 adrenergic receptors, sedation with limited effects on respiratory drive, which decreases the risk of hypoxemia, a lack of anticholinergic effects, and analgesia. The later include primary analgesic effects as well as augmentation of opioid-induced analgesia. Stimulation of alpha 2 receptors in the substantia gelatinosa of the dorsal horn inhibits the firing of the nociceptive neurons. Again, dexmedetomidine acts mainly presynaptic on the alpha 2 receptor, reducing the release of norepinephrine from the presynaptic membrane. Although it resembles clonidine, it's actually 8 to 10 times more specific than clonidine. And as we mentioned, end organ effects include sedation, potentiation of opioid-induced analgesia. So that's why we utilize it a lot in the OR right now as an adjunct to the opioids. Centrally, alpha 2 adrenergic agonists also reduce central norepinephrine output, leading to the central sympatholytic effect with a decrease of heart rate and blood pressure. This slide is basically a comparison between clonidine and dexmedetomidine. As you see, dexmedetomidine is much more selective than clonidine on the alpha 2 receptors. And clonidine is mainly used for hypertension. Could be used for sedation, but mainly for hypertension. While dexmedetomidine is primarily used for sedation. The half-life is 2 hours for dexmedetomidine and 8 hours for clonidine. I like this slide showing the different mechanism of action of different drugs. So if you look at it here, we have 6 steps, starting from transduction, conduction, transmission, modulation, perception, and CNS responses. So clonidine and dexmedetomidine works in this area. Modulation. Dexmedetomidine reduces the noradrenergic output, as we mentioned before, from the locus ceruleus. And this allows for the increased firing of inhibitory neurons, including the GABA system. Sleep and sedation induced by dexmedetomidine resembles that of non-REM sleep and uh, it helps with restoration of normal sleep cycle. Dexmedetomidine has the potential to regulate sleep in patients with delirium who have disruption of the circadian rhythm as part of the initiating and potentiating factors in delirium. Primary analgesic effects and potentiation of opioid-induced analgesia result from the activation of the alpha-2 receptors in the dorsal horn of the spinal cord and inhibition of substance P release. As far as the ICU anesthesia, there is a growing evidence that dexmedetomidine may reduce the incidence and severity of delirium, reduce the opioid consumption, and postoperative nausea in the intensive care unit. It also used to facilitate withdrawal from different substances, such as alcohol, opioids, and heroin. Concerning safety of the drugs, some studies reported an increased rate of serious cardiovascular effects with pre-existing heart conditions, especially those with bradycardia and arterial hypertension. Since the drug has main hepatic metabolism, dose reduction is mandatory in patients with hepatic impairment. Dexmedetomidine works in 15 to 30 minutes, reaches a Tmax or time to reach the peak concentration in 1 hour, protein binding 94%, and it follows a zero order kinetics. Elimination half-life is between 2 and 2.5 hours, metabolized by the liver through glucuronide conjugation and cytochrome P450. Excretion is mainly urinary. Question: dexmedetomidine pharmacology. Onset 15 to 30 minutes, correct. Tmax is 1 hour after continuous IV infusion, yes. Protein binding 94%. Elimination half-life between 2 and 2.5 hours. So the correct answer is E. Adverse effect. The most important adverse effect for dexmedetomidine is hypotension. And this is related to reduce of the reduction of central sympathetic output, resulting in lower blood pressure and heart rate. So when I reduce the sympathetic output, you will have hypotension and bradycardia. So there's been a lot of work on that one, and this is the major side effect for dexmedetomidine. So again, bradycardia follows hypotension as a major side effect for dexmedetomidine. So you have to be careful in patients with heart block and bradycardia. As far as respiration, it does not reduce the minute ventilation like other drugs like opioids. And this is the main advantage of dexmedetomidine. Even the blunting of the carbon dioxide response curve has been only noted in very high doses. Question: common side effect of dexmedetomidine: hypotension, bradycardia, nausea, respiratory depression. Hypotension. followed by bradycardia. Absolute contraindication if you are allergic to dexmedetomidine, or if you're having a severe bradycardia or advanced heart block without a pacemaker. Withdrawal symptoms. Dexmedetomidine is one of these drugs that you cannot stop abruptly. You have to do it in a gradual fashion. Okay? So you don't get withdrawal symptoms. What are the withdrawal symptoms? Rebound hypertension, tachycardia, agitation, tremors, and insomnia. Another question. Dexmedetomidine withdrawal symptoms. Rebound hypertension, tachycardia, agitation, tremors, and or all of the above. The correct answer is all of them. Role of dexmedetomidine. So we can classify it into three main categories. The most important one, as far as we're concerned right now in medical practice, is ICU, like hyperactive delirium, sedation for mechanical ventilation, anesthesia for post-operative pain, for conscious sedation, to reduce opioid consumption, prevent opioid-induced hyperalgesia. Others, such as palliative care and emergency department. Another question, role of dexmedetomidine, ICU, anesthesia, palliative, ER, all of the above. The correct answer is all of the above. But the main one, guys, right now are basically ICU and anesthesia. How about in palliative care? Well, it can be used in palliative care in hyperactive delirium, palliative sedation, opioid-induced hyperalgesia, and intractable pain not responding to opioids. Dexmedetomidine and palliative care. There have been sporadic case reports about successful use of dexmedetomidine in palliative care. And the nice thing is you can mix it in a syringe drive with other drugs such as morphine, hydromorphone, and haloperidol. So in 2021, a prospective study was available that reported promising results for dexmedetomidine in hyperactive terminal delirium for reducing delirium intensity and agitation. Dexmedetomidine dosing in palliative care, basically 1 mic per kilo, and followed by continuous infusion of half mic per kilo per hour. But I mean, you can always tailor this dose, not to a higher dose, but lower dose. Let us say the patient is kind of a little bit hypertensive. Maybe you can cut down the dose by 50% or omit the loading dose. So, you know, you have to titrate according to your situation. Dexmedetomidine can be administered intravenously and subcutaneously, which is a huge, advantage. Also can be used in other situations in the palliative care setting, like intractable pain, blunt opioid-induced hyperalgesia, and treating delirium, as we mentioned, hyperactive delirium. Indications of dexmedetomidine in palliative. Hyperactive delirium, correct. Palliative sedation, correct. opioid-induced hyperalgesia, and intractable pain not responding to opioids. The correct answer is all of the above. Dexmedetomidine can be given subcutaneously, can be given IV, and this is some of the articles from the literature. This one I like a lot. A magic bullet on its way into palliative care. And the other one, applications of dexmedetomidine in palliative and hospice care. Key learning points. Dexmedetomidine is currently FDA approved in the United States for short-term sedation of adults in the ICU and for monitored anesthesia care procedural sedation in adults. Extended clinical use has resulted in significant clinical experience in other clinical scenarios in both adults and children, including palliative care. During end of life, dexmedetomidine has been used to provide sedation, control adverse effects of other medication, manage symptoms of delirium, and provide primary analgesia in addition to augmenting opioid-induced analgesia. Its unique mechanism of action provides sedation with a decreased risk of delirium when compared to others. Also, it can provide anxiolysis and sedation, and you can still maintain a responsive state for interaction with family members, meeting a common priority in palliative. Also, we can add to this, it has less respiratory depression effect than opioids. So when you combine it with opioids, you reduce the incidence of respiratory depression, and at the same time, you're augmenting the effect of the opioid analgesia. Thank you.